So I wish I could start out by saying that there's a perfect measure for sodium intake and potassium intake and that all studies used it, but as you've already heard, we've got lots of limitations and some strengths and a wide variety of measures being used. So I'll be covering biomarkers, the 24-hour urinary excretion, partial and spot urine samples with and without an estimating equation, and then various methods for self-reported intake. So I'm also going to admit very early on that dietary intake is measured with error. And fortunately for us, as are many other variables, and there was a discussion about blood pressure, but fortunately for us, because there was this early recognition and acknowledgement within the dietary assessment field, we know a lot about the measurement error and what it does in dietary intake assessment. So there are two kinds of errors, got the wrong button. There's systematic error, which leads to biased estimates such as mean and effect sizes. There's random error, which leads to less precise estimates and it affects the variance estimates. So as you can see in the lower left corner, this is depicting random error with minimal bias. The sample average is actually very close to the blue line in the true intake, but there's a lot of scatter or variance around those estimates. And this one is bias. There's bias but minimal random error, and you can see that there's a big difference or a bigger difference between true intake and the average, but very little scatter around that. And this is just depicting the situation with both. So I also want to talk a little bit about usual intake. People have been discussing it a little bit, but it's the average over a longer period of time than just a single day of intake. And it may not be representative for an individual. You've heard that. It introduces random error. But a single day can be used to estimate the mean usual intake for populations and groups if there's very little bias. So you need multiple days to estimate usual intake for an individual. That's true for 24-hour recalls, food records, and estimates using urinary excretion. Depending upon the outcome, you may need very long-term usual intake over a lifetime if you're looking at morbidity and mortality. And that's just something that is really difficult to do in dietary studies. So I'm going to start with biomarkers for sodium, and you've heard a little bit about 24-hour urinary excretion. Most consumed sodium is excreted in the urine, very small losses in sweat, and even less in stool. And in fact, balance studies, which are very carefully controlled, we know what people ate, where sodium intake is held constant, show that about 90% is recovered in urine. The range is about 85 to 95%, but that's if collection is complete. And studies have shown that it reflects intake over the past day, usually, but maybe up to 3 days. And to estimate usual intake, you need at least 2 to 3 24-hour urines. 7 or better. We've heard maybe even longer or more are needed. And some small feeding studies recently have documented monthly or longer rhythms in sodium excretion. Larry, independent of intake, Larry showed some of those graphs. So you really may need even longer-term samples or estimates, days, to be able to estimate usual intake. And I just want to point out that those balance studies are really very small and very limited population characteristics. So I said before that a 24-hour urine is good at assessing sodium intake. If it's complete, and there have been several methods that have been used to assess completeness. PABA is a biomarker that's recovered in urine. It requires some participant burden. They have to take a dose 3 times a day. The assay is costly, and basically very few studies use it. Urinary creatinine excretion has been used because it's less variable than urinary sodium and urinary potassium excretion, but it can vary by by day, age, muscle mass, and diet, so it's not really as reliable. Other methods that have been used are protocol, so a protocol to start and stop the urine collection in the clinic, questions about missing void, cut points for unrealistic urine volume, but there's really no consensus on the criteria. So the bottom line is that few studies describe the methods for assessing completeness of urine and collection, and especially if the studies are older. So because of the burden of collecting a 24-hour urine, there's been a lot of research on using partial urine samples, and there's been a lot on overnight collections, the sample from the overnight collection. While there's moderate correlation with a 24-hour urine, mean intake is underestimated, which introduces some systematic error. And the real problem is that there's this nocturnal dipping in urinary sodium excretion, and that diurnal variation has been shown to be differential by hypertension status, medications, sex, and race. And again, a single day may not be estimate usual intake. We assume it's the same for 24-hour urines, that at least 2 to 3 24-hour partial samples would be needed. So recently, there have been some equations that have been developed, and there are a number of them out there, that take a partial urine sample and estimate urinary sodium in this case. There have been there's been this blossoming of validation studies of those equations recently, and they all show that there's bias. So looking at bias, we mean the true estimate, the true minus the estimated excretion. And so we found, in fact, that it varies by the equation, by the time of day, morning, afternoon, evening, overnight, and by several participant characteristics. And most of these equations, or most of these validation studies, have shown that that there is a differential bias by the intake level, and usually there is overestimation at the lower levels and underestimation at the higher. I think I got that wrong. So there's I did get it right. Overestimation at the low levels and underestimation at the high levels. And these equations may not account, usually don't, for diurnal variation. As I said before, there's been some evidence of it being differential. And again, a single day, if you're going to use an estimating equation, a single day does not estimate usual intake, and at least 2 to 3 days of partial urines would probably be needed. I'm going to focus on one in particular because it's been used in several cohort studies that have received a lot of attention, and that's the Kawasaki estimating equation for urinary sodium excretion at 24 hours is predicted from, this is the equation right here, from the sodium to creatinine concentration and multiplied by the predicted 24-hour urinary creatinine. The creatinine is coming from or estimated from the sample, and it uses a second morning void. It assumes that urinary sodium to creatinine concentration is constant over 24 hours. Well, with the dipping that I talked about, I think that it's probably not a really great assumption. But I think that its use may lead to random and systematic error. So those validation studies that I talked about, most of them have found that the mean bias is high, except for one study, and that was the validation study for the peer study, which we'll hear about later. And in general, they find that the estimates are that urinary excretion is overestimated at the low and underestimated at the high levels. It doesn't account for differential diurnal variation, and you really need more than 1 day for usual intake, and the cohort studies only are using a single day, partial urine from a single day. So potassium, a 24-hour urine excretion has also been used as to get a biomarker for potassium intake. And we've already heard a little bit about this. The balanced studies have shown that the recovery in urine is quite variable, so 50 to 92%, much more so than sodium, which was 85 to 95%. And Larry already talked about this too. There is variation in the amount that is excreted by race and diet. So for DASH, blacks excreted 50%, whereas whites excreted 69%. But there is little difference between blacks and whites on the controlled diet. And as for sodium, monthly or longer excretion rhythms independent of intake have been documented in potassium, urinary potassium 2. There are some reliability studies looking at urinary potassium. If you think it's a good enough measure of intake, you would need at least 2 to 3 24-hour urinary potassiums. But given that it's really so variable and you're not really sure what you're getting, I think it's not really, it doesn't make sense to even use a spot or partial sample, because I don't think they're going to be valid. There have been some estimating equations that have been used, and the validation has shown very mixed results. There's also nocturnal dipping of potassium, urinary potassium, and that's definitely not accounted for in any of the equations that I've seen. So I'm going to move on to self-reported intake methods, and those that are recall-based, a 24-hour recall, and a food frequency questionnaire, and those that are not, which is a food record, where in theory a participant records as they eat, but in practice I think we know that they actually record at the end of the day, so it may be a little bit of recall bias in there too. So I'm going to talk about general issues for self-reported methods because they apply to both sodium and potassium. And energy intake is underreported on average. There's really fairly good documentation of that. And this underreporting is more serious for food frequency questionnaires than a 24-hour recall. It can be differential, so we know that people who are overweight or obese tend to underreport more than people who are at healthy weight. Portion sizes are not well estimated. It's very difficult to do. Not all sources of whatever nutrient it are captured, so salt added at the table. Some medications have either sodium or potassium or whatever in them, and those aren't captured. There are memory problems with, especially for a 24-hour recall, and if you're elderly, food frequency questionnaires actually have memory problems too. I think they both, in addition to food records, there will be intentional omissions. People don't want to admit to some of the things that they've eaten. I'll never forget the bag of 24-hour or of Oreos that was reported in NHANES 3. Somebody actually fessed up to that. The nutrient content for foods can actually vary in databases because of the varying level of information in the databases, or the way that the food composition was, if it's calculated versus if it's an analytic value. And then, of course, with all of the self-reported methods, a single day does not represent usual intake. If you don't get anything else from me today, you're going to get this issue of usual intake is important. So self-reported methods, issues specific to sodium. So given that about 70% of sodium that's consumed in the U.S. is from commercially processed foods, brand name and restaurant probing is really important. And you can do that in an interviewer-administered 24-hour recall. You can't really do that in a food frequency questionnaire. All of that detail is gone. You tend not to get that level of detail in food records. And then given the importance of that the commercially processed foods, updating the nutrient composition databases is really challenging, and so there's a lot of error associated with with just the lack of the information in both from the participant and from the databases. Sodium is highly correlated with energy, and so we assume that that sodium is underreported too, which will introduce a systematic error. And in fact, in some bias studies where you're comparing to a 24-hour urinary sodium, there is some estimates. There are some estimates of underreporting. It's modest for a 24-hour recall, only 4 to 13%. A lot more for a food frequency questionnaire, 28 to 39%, and then for food record, it's someplace in between, 15 to 30%. So there really is evidence for underreporting of sodium in these self-reported methods. So for potassium, the main sources are vegetables, fruits, meats, milks, and grains. And because of that, the correlations are lower. I think Larry showed some data and some actual estimates. Again, the bias now compared to a 24-hour urinary potassium, which we said may or may not reflect actual intake, there is very little underreporting for a 24-hour recall and for a food frequency questionnaire. But whether or not that is a gold standard is really questionable. So there we go. So what's the effect of all of this measurement error in our estimates? Well, this depicts the theoretical effects of random error. And so that this would be a direct association between usual intake and an outcome. When you have only a single day, that's the line in red, you see that the relationship is attenuated or biased towards the null. And this is a really recent study which shows that the shape of the association between urinary sodium and CVD is really altered substantially by the use of a single baseline measurement of a 24-hour urinary sodium versus some longer-term measures. So you can see, it's a little bit busy, but you can see in this black line here, this is the shape of the association using a single baseline 24-hour urine, and it's slightly U or shaped. And when you look at the hazard ratio for higher versus sodium intake, it's not significant. But when you use the average of, this is a 1-year and a 5-year average, you can see in the gray line, the shape is really quite different and in the opposite direction. And these are the hazard ratios, which are significant, showing that a higher sodium, with higher sodium, urinary sodium excretion, you have a higher risk of cardiovascular morbidity and mortality. So I want to remind you all of that the limitations may differ for group versus individual level analyses. When you're doing randomized trials, you're comparing treatment group means. And so the mean from a single day can estimate group differences, but you have to be concerned if there's differential bias. So if it's an intervention study, a behavioral intervention study where one arm is trying to reduce their sodium, then you really have to think about whether or not there is differential bias. Multiple days will increase the power to detect effects, so it's actually always good to get multiple days when you can. But in contrast, when you have individual level analyses, so looking at intake related to an outcome, a single day does lead to random error, regardless of the method that you use, except for perhaps a food frequency questionnaire, which aims to get usual intake. And as I showed, the error may attenuate or alter the relationship. Multiple days, in this case, too, will increase the power to detect effects. So I'm going to try and leave you with my own personal thoughts about where we're at with all of this. So for sodium, 24-hour urinary excretion is optimal if collection is complete. And That's, of course, my mantra has been, you need multiple days in order to estimate usual intake. I would be very wary of overnight urinary sodium and of estimated 24-hour urinary sodium from partial urines. And for those, because of the bias associated with that has been shown in those estimates or those ways of estimating sodium intake. Food frequency questionnaires, I'd be wary of them too because of the serious underreporting of energy and of the underreporting of urinary sodium in those relative bias studies. 24-hour recall and a food record may underestimate intake more than a 24-hour urinary sodium. For potassium, I think you really, I think there's just not consensus on whether a 24-hour urinary potassium excretion measure is really reflecting intake. And because of that, I'd be very wary of estimated 24-hour urinary excretion from a partial urine sample. 24-hour recalls, food records, and food frequency questionnaires may underestimate intake, but they may do as well or better than a urinary potassium measure. And if you're using urine biomarkers to estimate sodium and potassium ratio, you really have to think about what the urinary potassium is reflecting. Thank you.
Thank you very much.